Hi everyone. My project focuses on improving the detection of unhealthy alcohol use, specifically in primary care through standardized alcohol screening and brief intervention. Unhealthy alcohol use affects about 20 to 25% of adults in the US and contributes to over 178,000 deaths annually. It's associated with long-term conditions like liver disease and cardiovascular disease, but also short-term risks like injury and mental health complications. What stands out is that about 90% of individuals are not identified in healthcare settings, even though many of them are regularly seen in primary care. So the issue isn't access, it's that screening isn't consistently happening. That gap is what the project focuses on. My PICO question asks, in adults receiving care in primary care clinics, does standardized alcohol screening with brief intervention, compared with usual care, increase identification of unhealthy alcohol use over 12 months? To explore this, I conducted a structured literature review using PubMed and academic databases. I focused on peer-reviewed recent studies using terms like alcohol screening, ESPER, and primary care. The final articles included randomized trials, implementation studies, and a systematic review. I evaluated each based on study design, findings, and limitations to understand both effectiveness and quality of evidence. The results showed clear improvements when screening was standardized. Across multiple studies, screening rates increased significantly. For example, from 20.8% to 83.2%, from 17.4% to 57.6%, and from 2.1 to 35.5%. These increases reflect a shift from inconsistent screening to something more systematic. Another important finding was that screening led to more documented brief interventions, which is important because identification alone doesn't change outcomes. Some studies also show that these interventions resulted in reduced alcohol consumption at 12 months, suggesting that early identification can actually influence patient behavior over time. One thing that became clear is that the screening tool alone isn't enough. How it's implemented really matters. The most effective approach is integrated screening into routine workflow so that it becomes part of standard care rather than an extra task. EHR prompts helped ensure that screening wasn't missed, especially during busy visits. Provider education also played a role by improving confidence and consistency in using ESPER. Overall, the success of screening depended on system level support as much as individual provider behavior. From a clinical standpoint, standardized screening improves the likelihood that at-risk patients are identified early. Using a tool like the Audit-C helps make screening more consistent across providers, which is important in settings where care varies. Across studies, there was a clear pattern. Outcomes improved when screening was supported by structured systems like workflow integration and EHR tools. At the same time, variability in documentation and implementation shows that consistency is still a challenge in some settings. Overall, the evidence was strong and consistent. The studies included randomized trials and large implementation studies, which increases confidence in the findings. Strengths included large sample sizes and real world applicability, while limitations mainly involved differences in how screening was implemented and how outcomes were documented. In practice, this would involve using the Audit-C during routine visits, supported by EHR prompts and provider training. Outcomes would be monitored by tracking screening rates and comparing identification before and after implementation. In conclusion, standardized alcohol screening with brief intervention significantly improves identification of unhealthy alcohol use in primary care. When it's integrated into workflow and supported by system level tools, it leads to earlier intervention and better patient outcomes. Thank you.